Tendinopathy of the long head of the biceps brachii is a common source of shoulder pain that may be managed surgically with tenodesis or tenotomy. Tenodesis may be performed arthroscopically or open. We describe a technique for an all-arthroscopic subpectoral biceps tenodesis which achieves complete excision of the pathologic tendon while avoiding the complications associated with the open approach. Author disclosures are noted here. Diagnostic arthroscopy is completed, an anterior superior portal is established in the rotator interval, and the pathologic long-headed biceps is tenotomized at its insertion via radiofrequency ablation. The reverse field is established by placing the arthroscope in the subdeltoid space through the lateral portal and directing the viewing field distal along the humeral shaft. An ablator is placed through the anterior superior portal. The long-headed biceps tendon sheath is located at the medial aspect of the anterior lateral humerus proximal to the upper border of the pectoralis major tendon. The sheath is opened with the ablator and the long-headed biceps tendon is mobilized out of its sheath. An arthroscopic retriever is placed on the proximal end of the tendon through the anterior superior portal to provide physiologic tension when needed. Two subpectoral accessory portals are created, one proximal and one distal to the lower border of the pectoralis major tendon using an outside-in technique. An ablator is used to remove any connective tissue impeding visualization. The long head of the biceps tendon is clearly visualized distal to the lower border of the pectoralis major tendon by pulling the arthroscopic retriever. Note the short head of the biceps medial and separate from the long head at this level. With the arthroscope in the distal accessory portal and an ablator through the proximal accessory portal, the periosteum is removed from the planned location for suture anchor placement just proximal to the lower border of the pectoralis major tendon. A rasp biologically prepares the anchor site, and a 1.8 mm knotless suture anchor is drilled and inserted through the proximal subpectoral accessory portal. An arthroscopic grasper through the lateral portal retrieves the white passing sutures. The blue working suture limb is passed in a figure of 8 fashion at different depths through the long-headed biceps tendon at or just proximal to the musculotendinous junction via a suture passer through the proximal accessory portal. The white passing sutures are then returned to the proximal accessory portal. The blue working suture is placed through the loop of the white passing suture outside the shoulder and delivered through the anchor to deploy the knotless mechanism. The long-headed biceps tendon is cinched down to bone and excess suture is cut with an arthroscopic suture cutter. The tendon is cut 5 mm proximal to the suture anchor via a radiofrequency ablator through the proximal accessory portal. The arthroscopic retriever should now remove the cut tendon stump through the anterior superior portal along with the cannula. The long-headed biceps tendon excised will range from 80 to 100 mm.